This is Susan Bashinsky. Hi, I'm going to kick us off very briefly today, and then I'll introduce my dear colleague, Megan Cody. I work in the state of Missouri. I'm a professor of special education at Missouri Western State University, and I have the privilege of serving as a special advisor to the National CHARGE Syndrome Foundation Board, and I really appreciate that role. We are thrilled. We are up to 124 participants here to learn about what CHARGE syndrome is today. It's a passion of Megan's and mine, and so we are thrilled to be able to talk with you about it. I've been involved with learners who have CHARGE syndrome for almost 20 years in a pretty serious way. One of the young men that you'll see in the slideshow today participated in a research project I had at the University of Kansas, and actually 19 years ago. And since that time, I've been really looking more into CHARGE and studying CHARGE, and I've stayed in touch with his family. And it's we're just thrilled that you invited this topic and you want to learn more about CHARGE. So that's it about me. I'm going to turn it over to dear Megan and allow her to introduce herself and kick us off for today.
So hello everybody. My name is Megan Cody, and I live in the great state of Kansas, the neighboring state to Dr. Bashinsky. My paid daytime job is that I'm the Family Engagement Initiative lead for the National Center on Deafblindness. But like Susan was saying, I'm also a board member for the CHARGE Syndrome Foundation, and we're really happy to be with you today. I want to give you a heads up that this is sort of a part one today, is really about teaching you about CHARGE 101, what's it like, what's it mean, those sorts of things. And then on Thursday, we'll have a dynamic panel of moms coming to share with you their tips of the trade for what it's like living in the journey of raising kiddos with CHARGE syndrome across the age span. So the presentation on Thursday will be much more fun than the presentation today, because we really want to give you the medical explanation of the syndrome, so it will help you as providers be easier to help find the kids, refer the kids, and know a little bit about what it means when an individual has CHARGE syndrome. So what we will cover today is we're going to provide a brief overview of the diagnosis and features. We're going to talk about sensory systems and how the child experiences the world. And of course, this is generalities, because every individual on this planet, having CHARGE or not having CHARGE, is unique, right? So these are just general things that are typical things that occur across the board for kiddos with CHARGE. Then we're going to talk about processing effects on balance and motor development. We'll give you a little bit more information around some typical behavior challenges and what that means for their interactions with their environment. And then we're going to talk to you about early communication, because as a former teacher myself, and Susan is a lifelong educator of people that go out into the field and teach these students, if you do nothing else as a provider, you really need to work on communication, communication, communication. So in terms of prevalence, about 1 in 10,000 births worldwide is what CHARGE syndrome is. Parents who have one child with CHARGE, they have about a 1 to 2% chance of having another child with CHARGE. And you will learn a little bit when the women present on Thursday about there is issues with families when they do have a child with CHARGE, being fearful of expanding their families. And one of the moms that will be speaking on Thursday will be referencing this, but the chance of reoccurrence is pretty small. So where does the name come from, right? So the C of CHARGE stands for coloboma of the eye. And that really what that means is that it's missing pieces of tissue creates a keyhole in the vision of the child with CHARGE. And you'll be able to, in a future slide, see that in a photograph that we included. The H stands for heart issues, because typically kiddos with charge have to have heart surgery. It's not uncommon for them to have that happen and pretty early in life. The A really just means that they have narrowing of their nasal passages often. R stands for retardation of overall growth. So typically individuals with charge are sort of smaller in stature. The G stands for genital differences, and E stands for ear irregularities and or deafness. So how does somebody get diagnosed with charge? Oftentimes, well, the reason why is because of cranial nerve anomalies. There's also a CHD7 testing that can occur, and it's especially helpful in less clear cases, but it's always recommended. And the CHD7 gene provides instructions for making a particular protein that is found in many parts of the body before birth. And generally, it's believed that 80+% of instances of charge are caused by a mutation in the CHD7 gene. So the clinical diagnosis of charge relies on the manifestation of 3 major features or 2 major features and multiple minor or supporting features to receive the diagnosis. And as we move through these slides, we're going to be outlining those major and minor features for you all. So this is a picture that you'll see. There's 2 images on the screen right now. The top image is of a young child, and you can see a really close picture up of their eyes. And then the second image that's below it is a group of individuals, and a few of them are gazing up at the ceiling. The iris coloboma is really when they have an increased sensitivity to light. Retinal colobomas is meaning that they have an increased risk of retinal detachment. And then upper visual field loss is really common again for kids with charge. And what you'll see in them is that they're going to constantly be doing what they can to position themselves to be able to see. So this picture in the lower left of the 2 little boys staring up at the ceiling are doing that to help themselves orient to what's going on in the space and to be able to get more visual input. So cranial nerve 1, this is where, hold on, yep, Susan, you're taking over.
Okay, I was wondering if we changed plans. Thank you. In one of the previous slides that Megan reviewed with you, she said that cranial nerve anomalies are really one of the key diagnostic features of charge. And as we go through the next set of slides, there are issues, often issues with cranial nerve 1, cranial nerve 7, cranial nerve 8, cranial nerve 9, cranial nerve 10. And as educational professionals and family members, you might go, I don't know anything about that. And what we're saying to you, or we want to say to you, is that's okay. We just mention this and mention that there's major involvement of up to 5 of the cranial nerves, which is almost half of the cranial nerves. And you know that your head and neck has so many nerves that feed directly into your brain that if there are issues there, the ramifications for development and learning and communication are pretty significant. So we have the numbers on the slides. If you want to ignore the numbers of the cranial nerves, that's just fine with us. We were just trying to include them to make the point that charge can honestly involve almost half of the cranial nerves, some kind of problem with those structurally, physiologically, so that you're aware that these are some of the major features of charge. Remember, Megan mentioned there have to be 3 major features or 2 majors and supporting minor features. So one of the major features is a decreased or absent sense of smell. And it's so funny that we now have some people in our world, funny is a bad choice of word, I'm sorry, it's unusual that we now have so many people in our world that might be able to relate to that. Since COVID, one of the characteristics of COVID is you lose your sense of smell. I've always thought, I can't even begin to imagine what it would be to live without a sense of smell. And sadly, now some people can relate to that. It's not 100% of learners who have charge, but it is estimated to be more than 90% of individuals who are determined, diagnosed as having charge, have an absent or decreased sense of smell. And I think your minds will just do a roller coaster at this point, because if your sense of smell is different, that probably changes the taste of food. It either diminishes or eliminates the taste of food. And then you go, oh, what does that mean? Well, then there are implications for feeding and kids who have failure to thrive, because as Megan said, most of the babies born with charge, they're very, very ill. And it's not uncommon. You'll hear the 4 mamas who will talk to you on Thursday talk about the number of weeks or months that their new baby was in a NICU or a PICU because of just health issues and trying to keep their kids alive. And so there are issues for feeding. Another thing that I think is very interesting about this feature of the sense of smell, if the learners have no sense of smell, that is often associated with a lack of spontaneous puberty. So as the kids get older, that's another challenging question that families need to face. And I know at least one of the moms is going to talk with you about that, okay, so what do we do? Do we want to go with hormone injections? What do we want to do? Because we have to deal with this issue of puberty. And then just in terms of social interactions and the kinds of things that I think we as teachers can relate to more easily, think about the social implications. If a learner, particularly upper elementary, secondary learner, isn't aware of the sense of smell, what about their own body odor? They don't sense it. Well, what's going to be off-putting potentially to peers is body odor or passing gas. If their feet smell and their shoes smell in gym, or when they have to change in a locker room. And so this notion of the sense of smell, when you first hear it, you might tend to go, not a big deal for me as a teacher. Might be. I think that's what we're trying to suggest that you think about. Megan, could you move it, please?
And before we go ahead and move forward, this is Marilyn speaking. There is one question that was on a previous slide. Kayla is asking, is the 4-H description of charge not happening anymore? I know the name was going to stay the same, but I thought not every person with charge had all those that you listed. And before you answer, Megan or Susan, let's go ahead and do an interpreter switch. Hold on one second. Okay, thank you.
Megan, you want to take it? You want me to take it?
You can go.
Okay, you are absolutely correct in that it is no longer required, and I'm doing air quotes, that an individual must display characteristics or impairment in all of those 6 letters that comprise the CHARGE acronym. But Megan read those because there was a whole lot of discussion in the CHARGE community, particularly in 5 to 6 years ago, more so than currently, about, well, because we no longer demand that an individual show some kind of issue or problem or impairment in all 6 of those letters that make up the acronym, we need to change it. And there was kind of an outcry from a lot of families as well as professionals going, no, CHARGE as a name has an identity. So we're going to hang on to the CHARGE acronym as an identity for learners with this particular disability. But the diagnostic criteria have changed to what Megan explained about 3 major features or 2 major features plus some of what we are going today to describe to you as minor features. So there's a collection, and it's choose so many of this collective. And if the individual demonstrates so many of this collective from these different categories, they qualify, again with air quotes, for a diagnosis of charge. Does that make sense, Megan?
Yes.
Does that make sense to the person who asked the question?
And she says, thank you.
Okay, thank you. Moving on then. Again, we've put the numbers of the cranial nerves, but you may ignore that part. Facial palsy, very, very common. For those of you who might not be able to see the screen, this is another one of our favorite kids whom we don't have, but I think all teachers know we do have. This is Miss Lacey, and she is wearing a purple ball gown with a handmade crown of paper mache that she and her mom created. And in this picture, she's about 10 years old, and she was going to a school dance. But it shows in her facial features this diagnostic criterion of facial palsy. And for those of you who might not have ever met an individual with charge, if you just glance at a person's face, it might make you think of Bell's palsy. Maybe that's a little bit more familiar, or a person who is in the throes of initial stages of a stroke where they get a lopsided face and one side of their mouth might droop. That's typically what is defined as facial palsy. In Lacey's picture on the screen, the left side of her face and mouth has some kind of a droop that is described as a unilateral or one-sided drooping, and it's casually described as a lopsided face. And we're not trying to be derogatory when we say that, but a lopsided face. This facial palsy, if it affects the cranial nerve on both sides, it can be bilateral. And then it's really very difficult. Again, you might, as teachers, might go, okay, well, what do I care? What do I need to know if cranial nerve 7 is involved? Well, it is important, because if a person, even with a unilateral palsy, but especially with a bilateral palsy, it's really, really difficult for that individual with charge to show any facial expression. I mean, think about it. If you try to smile, if you try to frown, if you try to gasp and open your mouth, it's really difficult, depending on the degree or severity of the palsy, to know what that individual is feeling, right? And emotions are so important. And especially if we're trying to teach communication, lots of times kids who don't have conventional communication yet, they use their emotions and their facial expressions to show us how they're feeling and what they want and need, right? Well, if kids are struggling with a bilateral facial palsy, they can show you with their face what they're feeling and what they want and need. So it's these layers that compound one another that make formally educating and interacting and improving quality of life for learners with charge a real challenge. Megan, could you switch it for me, please? Okay, again, cranial nerves 9 and 10. Skip that part. Go with swallowing problems, all right? And so I'll start. There's a picture of a little beauty on your screen. The young child looks maybe 3-ish to me, and smiling at the camera. She has a Baha, which you'll hear about, a bone-anchored hearing aid, and she has a trach. You can see it. She has a G-tube for feeding, and you can see in the picture that a care provider is feeding water into a syringe that's going into her tube right now. But the reason Megan and I chose this picture, one, it's a good illustration of what tube feeding might look like, but also it shows that even at a very young age, And even when, a child might have multiple challenges intellectually, physically, as well as CHARGE syndrome, that child can partially participate, can be actively engaged in the activity of receiving a tube feeding because she's holding the plunger for the syringe. She's holding the bottle of water with which she's being fed. So she's engaging in that activity. And that's our challenge to you as teachers and education professionals is no matter what, find a way that these kiddos with CHARGE, even when they're little bitty people, can help and actively engage in their care. The categories, the characteristics, you can read them. It says because of the swallowing problems, many children will require G-tube feeding. With many of them, it will last for years. With some of them, it will last for a lifetime. With lots of learners with CHARGE, a G-tube feeding can be reversed, but not always. If there is a successful reversal, adults with CHARGE tell us that they still have to be cautious in terms of the textures or some of the foods they eat because they might still experience some choking episodes. Within the first 2 years of life, aspiration of food, aspiration of liquid is the most common reason for hospitalizations with kids who have CHARGE because they got swallowing complications and so they aspirate. And, Megan mentioned in her opening remarks that these kids, they're in the hospital a lot. They're in the hospital frequently for scheduled procedures. And in the case of aspiration, for emergency kind of visits. And all of the mamas that you'll hear from on Thursday will talk about this. Reflux is common. And again, a gastrostomy may be needed to reduce those aspiration problems. If a family rushes a child to an emergency room enough times because of aspiration, they're going to ask for an alternative way to feed and get that child to thrive. The next one, choanal atresia or choanal stenosis. I'm going to go back to the explanation Megan gave you because it was great. The choanae are just the openings at the back of your nose. And if there is atresia or stenosis, it just means that way back at the very back of your nasal passages, they're either very, very narrow or they're blocked. And you can understand if they're blocked, you're going to have a real problem breathing because you can't breathe through your nose, right? Even if they're very, very narrow, it can create a lot of issues with respiration. This can be difficult to diagnose. Obviously, you need a medical professional to diagnose this, but kinds of things that you as educational professionals and families can look for. If kids are just gooey, and Megan and I laugh about that word, we're not trying to be disrespectful, but sometimes kids are just gooey and they have goopy noses or frequent ear infections. If they show fluctuating hearing, which might be indicative of fluctuating hearing loss, this can be a sign that you've got some blockage or narrowing going on, which then if kids get an upper respiratory infection, it's just going to be exacerbated by that. There is a picture on the screen. Honestly, we just thought this little guy was cute because we really thought he was much more attractive to include than a picture of the anatomy of the nose. So it's just a little guy using a walker and chewing on a stuffed animal as he's boogieing down the hotel lobby at one of the conferences. Megan? Thank you. Now we're going to start talking about the ears because the ears are huge in CHARGE. This is the 8th cranial nerve. I guess we got tired of putting the nerve numbers on there. And this slide is really limited to comments about the outer ear. Maybe that's why we don't have 8th cranial nerve on here. I don't know. There are 5 pictures at the bottom of this slide that just show how very different the external or outer ear of persons who have CHARGE syndrome might appear. I don't really know how to describe them. Some of them are are fairly funky. One of the things that you'll notice in all but one of the images, they really don't seem to have earlobes. The bottom part of the ear before the lobe is just attached to the scalp. Some of them, like the middle picture, does have a small earlobe. You'll notice that there is sometimes a lack of the outer rim of the ear, of the what's called the pinna. The pinna are the outside parts of your ear. Sometimes the ridge is really thick, like in the second image from the left, or it's really deep, like in the fourth image from the left. The far right image, there's almost no rim on that ear. Overall, the ears, the outer ears, they're short, they're wider. Some kids' ears are really floppy. It's very, very common that the two ears of one individual with charge don't appear the same on the outside. So there is an asymmetry between the two outer ears. Megan, please. Thank you. Now we're going to talk a little bit about the middle and inner ear. The middle ear is where the bony structures appear that manage the conductance of auditory signals. And it is very common that those bony structures are misshapen, or let's say shaped differently than neurotypically developing children. Sometimes one or more of those bony structures is absent. Oftentimes these kids will have conductive hearing losses and that really aren't assisted that much by tubes. We can't say that there's no child that's ever benefited from having tubes in their ears. We're not saying that, but we're also saying that in our experience, it's common the kids may not gain benefit from having tubes in their ears. The inner ear is where the most impactful challenges of charge syndrome manifest themselves. Again, if your outer ears are different, like we showed and discussed, you look a little unusual, but functionally that's not a big deal. The difference in functionality of the hearing capabilities of people with charge primarily, not solely, but primarily are due to changes in the inner ear. And there's all kinds of things that are going on in the inner ear. Almost all kids with charge will have some kind of hearing loss. Many kids with charge will be deaf. Many kids with charge will be deemed candidates for cochlear implants if their families want to pursue that avenue, but many kids won't. Some kids with charge don't have an auditory nerve on one side. Cranial nerve 8 is just missing. Well, there's no point in getting a cochlear implant if there's no nerve to which it can send signals, right? The cochlea is in the inner ear, and the cochleas, that's the spirally thing that looks like a snail shell. That's where the signals that come in, the auditory signals come in, are translated into electrical signals to go on to the auditory nerve and get to the brain. And it's like a keyboard that's wound around. And in many kids with charge, the cochlea isn't complete. It doesn't have that full spiral. So it's only got part of the keyboard, all right? Another thing that's common among kids with charge is the cochlea can be really spongy. And if the cochlea is really spongy, it makes it very difficult, if not impossible, for a surgeon to get a cochlear implant fully inserted throughout the cochlea. Now, some families will choose to go for an implant, even if it's a partial insertion, thinking their kids will benefit from that to hear environmental sounds, even if they can't hear the full speech range. But that is where the hearing problems emanate from. Another thing.
Hey, Susan?
Yep.
Let's do a quick interpreter switch, please.
Good, I'll get a drink.
Yeah. All right, you're good. Thank you.
Yeah, just stop me. Another element another anatomical element of the inner ear is the semicircular canals. the three canals that operate in the three planes of the body. And as Megan mentioned when she introduced our talk to you today, many kids with charge will show you, they demonstrate balance problems, motor problems, issues with what a lot of medical professionals will call the vestibular sense. And that, although the vestibular sense isn't totally governed by what's going on in the semicircular canals, it has a whole heck of a lot to do with the semicircular canals. And in learners with charge, sometimes one of the three is missing. Sometimes two of the three semicircular canals are missing. Sometimes they're all three there, but they're malformed. And that can really, especially if on one side all three are there, and on the other side there's only two semicircular canals and you're out of balance, it really can complicate kids trying to balance themselves, maintain their body position in space. Kids with charge walk much later typically. This is part of what's going on. And it also can be complicated by vision loss because there are vestibular receptors in your eyes too. So it's just, the inner ear is a major deal in diagnosing kids with charge. It's very, as I said before, I'm repeating myself, hearing loss of some degree is so common. Megan and I would just, ask you to have the kids tested early, have the kids tested often, and for you as education professionals to stay abreast of the kids' hearing status. Okay, Megan? What is it like? We could sort of say yes. Is there hearing loss in charge? Yes. What type of hearing loss? Yes, all types. What degree of hearing loss? Yes, all degrees. And that sounds like I'm trying to be facetious, but I'm really not. Learners may show a mixed hearing loss, and by that we mean both sensory neural and conductive. Learners may show fluctuating hearing loss, as I mentioned before, because if they get a respiratory infection, they get fluid in their ears, then their hearing is going to be in and out, depending on how much fluid is retained in their ears. You know that. They may or may not respond to a cochlear implant for the reasons I explained in conjunction with the last slide. They might benefit from and might need a BAHA, which most of you have heard, I'm sure. The little gal in the picture with the tube feeding had a BAHA, which is a bone anchored hearing aid. Some kids with charge may show a progressive pattern of hearing loss. I'm really not being facetious when I say it's all over the map, and it's really hard to predict or to describe what the nature of hearing loss will be in a learner with charge. Just, I think Megan and I would both caution you to expect something. And I'll let her comment on that and turn it back over to you, Megan.
Sure, thank you. This is Megan speaking. So our next slide talks about some of the minor features that may be uncommon in other syndromes. And on this slide, there's two pictures. In the lower left-hand corner, there's a young lady laying on the floor who you can see by the way that her ankles are placed on the floor, that she has some pretty low muscle tone or hypotonia. That's a mouthful for an afternoon, isn't it? And then on the right side is a young man named Lance who was featured in a previous photo with his family. And the reason we put these two kiddos on these slides is because oftentimes kids with charge, if they do have hypotonia, which is really low muscle tone is what hypotonia means, oftentimes they prefer to crawl on their back, right? Because it takes so much more muscle tone to move over onto your stomach, bear weight on your hands and knees, and crawl across the floor. They oftentimes also bottom shuffle. So you'll see them seated on the ground where they have their balance. And then instead of choosing to use their legs to sit up, they'll just keep their bottom on the ground and scoot across the floor. And also too, when they have low muscle tone, it can be complicated even further by having poor balance, which again goes back to things Susan was mentioning in terms of if they have issues with hearing and things of that nature, it impacts their ability to have good balance. The picture of Lance on the right in the red and blue sweatshirt that says Old Navy on it, we included here because oftentimes kids with charge also have slumping posture where you'll see that they're sort of just slumped over, and they have sloping shoulders, which this picture of Lance, you could see, it almost looks like he has very little differentiation in his shoulders from his neck to his shoulders. And that is not an uncommon thing to see in kids with charge. Some characteristics of the face. Oftentimes the kids look like they have a little bit of a squared off face. And in the photo that you see on our slides right now, there's two individuals sitting together who are absolutely darling, and both of them have a little bit of a squared off jaw on the bottom. They oftentimes have broad foreheads and super deliciously cute round eyes that make you want to look at them and engage with them because they're so cute. They typically have a prominent bridge on their nose, and sometimes can have a smaller chin that may or may not get bigger as they age. So some additional supporting minor features of the diagnosis of charge would be a heart defect. And we mentioned this earlier. They may have to have multiple surgeries across a long-term basis to help with their heart. They oftentimes have issues with their esophagus and trachea. And in multiple pictures we've shown you today, you've noticed that individuals have had tracheostomies. They have often kidney problems. Approximately 30 to 40% of individuals that get diagnosed with charge have kidney problems. They're typically a little bit shorter in stature, which I know we've mentioned to you on previous slides. And in one of the earlier slides, I was remiss in mentioning that the young man, Lance, that was in the picture with his family, he appeared to be the second shortest kiddo in the family, when really he is the oldest child that happens to be the second shortest next to his younger sibling. And so oftentimes their siblings outgrow them and get taller than them. They have oftentimes genital abnormalities, and then sometimes facial clefts are an issue where you'll see a cleft lip and palate. And we're going to show you a picture on the next slide. Susan?
Thank you. This is Miss Lacey, the Purple Princess, from the previous slide that I showed you when we talked about the facial palsy. And there are two pictures on this slide. And maybe we should say to you, we do have permission from these kiddos whom we know. We have permission from their families to use all these images. They actually sent them to us. So I want to make sure that you're reassured about that. There are two pictures on your screen right now. On the left is a tiny baby. She's just over 3 months old, and that is Miss Lacey when she's approximately 3 months old. And it shows there that she has a bilateral facial cleft. She also had a cleft palate, cleft lip. This is a picture that illustrates, I think, how serious the clefting might be, and that it really does require a series of surgeries over multiple years. Again, that's a comment Megan's made. We're just going to keep making it because as kids grow, there has to be more work done to repair the clefting, and plastic surgeries involved. The picture on the right is maybe not the most flattering of Lacey, but she's intentionally sticking out her chin, which makes her eyes close because she has muscle issues with her eyelids, but she wanted to she was trying to highlight for her mama who took this photo, look at my beautiful lip and look at my beautiful repair. This is after the final repair surgery. She had 13 years after her first surgery. And if you look at it, although you still see the lopsidedness because of the facial palsy, she's gorgeous. I mean, isn't she beautiful? Look at her complexion, look at her lip, look at the area above her lip. You don't even see any scarring. I mean, she's gorgeous. And it just shows you what can be done. And Megan and I debated whether we should include this picture on the left for you, but as deafblind specialists, as folks involved with deafblind projects, we really thought that it's important that you have this information so that you can reassure families that, oh man, it may not be okay right now, but it can be okay and it will be okay. You know, today doesn't predict the future, because look at Lacey now. She's absolutely beautiful. Megan, please. And this is another picture just of two very handsome dudes at one of the conferences. You can see they're shorter. We know they're older than they appear. They're good buddies. They're friends. They just were tearing up Jack at the conference and had their picture taken. And we just want to emphasize, if we had all the time in the world with you, we would say this statement, I think, after every slide. Megan said it a couple of times already. Every single feature that we've discussed, the majors, the minors, all these things, can be absent to present in a very severe degree in different children who have CHARGE syndrome. No one feature of all the things we've discussed is seen in every single learner who has CHARGE, but many of them are. And that's why the diagnostic criteria has been broadened, that certain things in different categories, then you qualify. But I like to think, I'm sure you've all heard the phrase at some point, excuse me, oh, you've met one person with autism. I'm not talking about autism, I know that, and the response typically of a family or a teacher is, well, good, you've met one person with autism, good for you. That doesn't tell you anything about the other kids or young adults with autism. And I think Megan and I would say the same thing to you about CHARGE syndrome. You've met one person who has CHARGE syndrome. Well, good for you, because the next one you meet might be incredibly different, because the variability is huge. It's very, very, very different presentation. Megan, please. Other characteristics: a significant number of individuals with CHARGE experience seizure disorders, and they may develop at any age, just as you might have experienced with other kids with other disability conditions. Sometimes puberty will onset seizures, and once in a while, puberty will make seizures stop that had previously existed. There might be some kind of apnea, where kids will stop breathing momentarily particularly when they're sleeping. An issue in today's world is their compromised immune systems, because there are many different types of abnormalities in their immune systems. Constipation. The whole digestive system can be really a challenge for families to manage kids' bowel movements. Kids will be really suffering in pain because of constipation. I know at least one of the moms on Thursday is going to talk about this. It's not uncommon at all. Typically, the learners with CHARGE, the vast majority, will gain control of their bladder and bowels and be completely toilet trained, but usually on a delayed basis. Kids often have sleep disturbances other than the sleep apnea that I mentioned above. They just have unusual sleeping cycles, or maybe I should say non-sleeping cycles, because that's what we hear about. Sometimes they will have cyclic vomiting, which again, things get blocked up. And that sounds gross, and I'm not trying to be sensationalistic, but sometimes the only way to get rid of some of the food that's been ingested is for vomiting to occur. And some of the learners with charge will have a real increased need for sensory input, depending on the degree of their vision loss, because of the colobomas that Megan talked with you about, and the hearing loss about which I spoke with you. If those information gathering senses are impaired to some degree, the learners will crave sensory input from any place they can get it. So it's important that we remember that. Next one.
This is Robert. Let's go ahead and pause and do an interpreter switch right now. Thank you. I think we're ready.
Okay, thanks, Robert. Okay, the last slide I have for you, and then Megan's going to finish it out for us, is to talk about intelligence, cognitive abilities in learners with charge. And on your screen, you have a picture of just a darling little fella. And I don't know if this is a sibling or a caregiver. I don't know. But again, it's really hard to find a picture that illustrates intelligence. So we just wanted you to have another cutie pie to look at while you have to listen to me talk. I think that I'm not mistaken when I say uninformed, uneducated folks who would first encounter a person with charge might be more inclined to estimate that that particular individual would have lowered cognitive ability, simply because their external appearance often presents as very different from what we typically expect to see in developing children and young adults. And it's just not a safe assumption to make, full stop. Approximately 40% to 50%, that's half, people, approximately 40 to 50% of individuals who have charge have no apparent cognitive impairment, none, even though they look oftentimes as though they might have significant cognitive impairment. So what we, Megan and I, are asking you, please, 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 always presume competence in those learners, regardless of how many physical needs they might present to you. Always presume they're competent. And focus on communication to get them a way to communicate so they can let you know that they're competent. The loss of their distant senses, and these are all three of their distant senses, right? Vision, Megan talked about that. Hearing and smell, I talked about those. Man, those are the only three ways we have to get information from the world at a distance. And if those are impaired, it can really create misconceptions in a family's mind. It can create misconceptions in a team's mind about what that learner can and can't do. So always presume they're competent and keep high expectations. Thank you. Megan, I'm going to turn it back over to you.
Yeah. So this is Megan speaking again, and I would add to that, as someone who teaches them, or if there's parents with us today, as a parent, if they actually do have loss of distant senses, it's up to us to give that to them, the context of what it is that they're missing. Otherwise, they're not having an equal chance for interaction within the environment. So as educators, it's going to be really important that you slow down your teaching. I often say it's the journey to get to the classroom that's almost as important as being in the classroom, because things that occur in the hall that we all can just fairly effortlessly navigate and absorb, whether it be artwork hanging on the walls, people walking by and chatting, knowing to avoid someone in the hall, all those sorts of things that even allow a child to make a transition from one classroom to the next you need to afford them the time to have that experience and not rush them through their day to get to that next class, because their rear end is just supposed to be in their seat at the start of the next class. It's about making every single interaction, transition, meaningful, relevant, and understood by the learner, because if you don't, you're going to increase their frustration, increase their fear, and most likely inhibit their ability as the primary communication partner for them to feel comfortable interacting with you and trusting you. So give yourself time to build those transitions and build those routines in a way that's respectful to them gaining access to the information that they may be missing because of those loss of distance senses. So,
excellently said, Megan. Great points. Thank you.
Sure. So this next slide says sensory characteristics in charge. And you're going to be like, well, hello, you told us about a lot of these, but we wanted to put them together on one really nice slide for you. And in this picture, you're going to see Lacey again, the girl that you've seen multiple times that had the purple and pink sequin outfit on, and the girl that had the cleft palate repair. This is her just a few weeks ago bathing her dog that she got during COVID, which is pretty cool. So this is her in pretty current time. I love this picture, and we put this picture on because you can see her cochlear implant so clearly in this picture, which is why we shared it with you. So the first thing is vision loss. We've talked to you about this, but it's really in two ways that vision is pretty significantly impacted in terms of field as well as acuity, right? So let's go back to that example I just provided. You're helping a kiddo or a learner with charge get from one class to the other, right? And what they can see and how clearly they can see it is impacted. We need to slow down and help them feel safe when that's happening. Hearing loss, as Susan has mentioned, it can be mixed, and oftentimes it's severe. So it can be really alarming, again, when you're walking down the hall. If things are coming at you in a fuzzy way, you can't see quite as far as your neighboring classmates scurrying through the hall, and oh my goodness, you can't really hear things that are coming from behind you or in front of you very well. Again, giving them that time to process what's going on and giving them the support that they need, either with their stature or with touch, to let them know where you are and helping them make those transitions. Those sorts of things are going to be really important. They also have balance abnormalities. And again, we've mentioned this before, but they're going to be more topsy-turvy, especially when they're younger and really beginning to learn how to walk and sustain strength to keep their legs up, etc. So being mindful of that and giving them the support that they need to develop that strength and to be able to ambulate safely will be important. With touch, you know, I used to always think that people had the same likings of touch that I did. You know, I always want to go to the softest blanket that I can find in the winter time, and I want to snuggle up and wrap it around my head and my shoulders and my neck when I'm watching the television because it feels good. But with kids and learners with charge, they do have sensitivity to certain textures. So don't assume that if you're providing instruction to a kid and they show an aversion to it, and let's just say it's I don't know, it's an early intervention kiddo, so it's a little kid and you're giving them a toy that has buttons on it. Don't necessarily assume that it's a button noise-making toy that's problematic for them. It may be that the slippery feature of the tops of the keys of the little play keyboard just doesn't feel good to them. And if you could cut some sandpaper and stick it on the top and give varying textures to the sandpaper, that they may enjoy it better. Or it could be the complete opposite, and they may find it to be an aversive situation where if a texture is too rough, that they wouldn't care for that. So we're trying to give you permission to experience and try different types of touch. The other thing too is that's touch with things you're giving them, but then there's also touch that you provide them as a parent or that you provide them as an educator. And so being respectful about how to cue them to get their attention and making some decisions around, are you going to touch them on the shoulder? Do you always need to be in front of them, or can you be to their side? Things like that, so they can predict who and what is coming at them, will also help them feel more stable. Sometimes they have altered sense of pain, and they can fall down and get hurt and not really let you know how badly they've been injured. So be aware of that as well. When it comes to smell, Susan mentioned before that sometimes it's absent or decreased. So again, getting them interested in trying new and novel foods. You know, you may think we're doing them amazing things by having them try Indian cuisine and, you know, you name it. They may not really care whether something's super spicy or not spicy, or really even too, that the whole smelling of it, it may not really matter to them. So if food is expired, they may not really be able to smell that it's expired. But taste is usually and possibly normal for kiddos. And I also want to make sure that people can take note of the fact that on the slide, we've demarcated vision loss, hearing loss, and smell with little star asterisks, because we want to make sure that you guys are aware that those are the three distance senses that Susan mentioned in a previous slide that are really affected typically when an individual has charge. So some gross motor characteristics. They typically like to stay close to the ground. Again, that slide that we had up earlier with the young lady that was lying on her back and had her feet like up and her ankles tucked in. They like to have their body near the ground. And the reason why is it provides them stability, especially if they're hypotonic. So it gives them stability, but then also too, it can help them then relieve themselves from that feeling of imbalance and wobbliness so that they can orient and use their vision and residual hearing a little bit better to make sense of their environment. So that's an important point to make. We're not suggesting that you have the individuals that you're teaching just lay on the floor during lessons, but making sure that they feel stable in whatever position that you're putting them in, seated in a chair or whatever, that they feel safe and comfortable so that they can use their remaining senses to actually get through lessons, etc. You'll also see that they creep or combat crawl a lot. And you guys know what the combat crawl is, where they're kind of, I don't know, it's almost like a spider that crawls that way. That's what combat crawl is. Sometimes they'll do a 5-point crawl, or they'll do the bottom shuffle, as we mentioned earlier, where they keep their bottom on the ground and they just, you know, scoot themselves with their rear end rather than standing up. And oftentimes, especially in the early years, kids cruise for a very long time before they decide they're going to take off and go running across the room. And the age of independent walking, they might walk as late as 3 to 4 years of age because, again, the associated muscle tone that we talked about and the vision problems, because if they have low acuity, they're going to be a little bit more scared to bound off on their own and start walking on their own. So don't give up on trying to help them in learning to walk. It just takes patience and it takes time. Important communication considerations in charge. On this slide, you'll see that we have 2 people interacting with each other, and it appears as if the boy that's in the teal shirt is doing sign language to the person that's in front of him in the red sweatshirt. And we put this in because we liked the fact that it was showing good communication exchange between 2 people. So vision, when you're thinking about, okay, I found out that I'm going to have a child with charge in my classroom, what do I do now? Some really important things to do would be to look first at their vision and hearing records to say, what is the learner's visual field? How well does the learner see? And do they possibly have a cortical visual impairment? Because this is all going to make a difference in terms of what your instructional practice will look like, right? What kind of materials that you need to give, which again, one of the moms that will be with us on Thursday sharing her experience will show a picture of her daughter in the slideshow that we're providing, where her daughter is waiting for the necessary materials that she needs to be successful using her computer at home because of COVID. And you'll see that they have her computer propped up on milk crates and that her child is all but right up on top of the screen. And it's because she was waiting for all of her adaptive equipment that helps her visually receive information in the classroom or even remotely because of COVID. And how important that is could be the difference between them receiving the instruction that you're going to give them and not effectively receiving the instruction if you haven't put those accommodations in place based on what you know to be their visual needs. The other thing too with that is hearing. Through what range can the learner hear? So how close as a provider do you need to be standing to them in order for them to receive the auditory information that you're trying to give them? How close do you need to coach their peers on how close to be to them in order to be able to have social interaction? And at what volume can the learner hear? You would be surprised, but depending on the tone of your voice, they may be able to hear you better than they can hear another person that's in their daily life based on how loud we speak, but also to the tone of our voice. Do I have a deeper voice or do I have a higher pitched voice? That can make differentiations in terms of how well they can hear from person to person, as well as environment to environment. The other thing too is they may have a central auditory processing disorder where information is coming in through the ears, but by the time that signal goes from the ears to the brain, and then the brain makes sense of it to allow you to know how to respond to it, there may be barriers in that way. And that's basically a rudimentary description of what a central auditory processing disorder is like. Susan.
One more comment before you go to the next slide, Megan. Another aspect, and we probably should have put it on here, is just in terms of if we have any audiologists, speech paths in the audience, when we're talking about what range the learner hears, we're also talking about from the lowest of the low sounds to the highest of the high sounds. And maybe kids can, with their residual hearing, they can hear environmental noises like loud lawnmowers or really loud cars or airplanes, but they might not have hearing in the range that is the speech range. And so in addition to all the things that Megan said, which are spot on, we're also, encouraging you to find out about what's the hertz range, high to low, and does that learner's hearing ability include that speech banana, the range of speech sounds? That's all. Thank you, Megan.
Sure. And this is Megan speaking again, but that will also make a big difference in terms of, again, how will they survive in a loud gym class? Will that work for them? How will they do in a loud cafeteria? Will that work for them? Thinking about what environmental considerations you need to put in place to allow them to feel safe and able to participate is going to be really, really significant.
Megan, this is Robert. Let's go ahead and do an interpreter switch.
Sure.
Thank you. We're good.
Great. So we only have 2 more slides for you guys, and then we're going to open it up to questions and answers. So this is sort of like our wrap-up slide, so that if we had a wish list that we could give to everybody that was on the call today, if you got nothing out of our time with us other than these things, these are the takeaways that we're hoping that you guys will walk away with today. You really need to know your learner, period, end of story. And knowing your learner involves understanding what's their vision status, what's their hearing status, how really are they on balance, what are typical changes in their overall health and mood. And that you can gather from families as you're receiving a new learner so that you can understand from the parents their medical history and what it's taken to get their child to the point that they're at right now with their kiddo. And it will help you also too know to watch for certain things. So as Susan mentioned, oftentimes recurring ear infections and things like that are common with kiddos. So if the mom and dad or the care provider can say to you, watch for this. Typically, when my child's starting to get the onset of an ear infection, you'll just find them like this with their hand up pushing on their ear. If you notice that that's happening, please let us know. Those types of signals that the kids and learners may be giving to you as providers. The other thing too is don't be afraid to report changes in mood and noticeable changes in health or behavior that you're noticing at school, and give that information to the family, because they may not have seen it yet at home, and it may allow them to get medical intervention sooner if something is needed. Observe carefully. And when I say observe carefully, I don't necessarily just mean the kid, I mean the family as well. This is my most important thing ever. Parents are the experts on their kiddos. And so really listening to what the parents know to be true about their kid, what it's taken to get them there, and what it is that they're hoping for their future and for their dreams is going to be really important. Observe them in different environments, observe them around different people, observe them around with different textures, observe them. Really get to learn what makes them tick, what are aversions to them, and when you find them most successful, most open to interaction, and most open to communication, because then you say, wow, they were really with it during that lesson and having a great time. What was unique about that lesson or that exchange that I need to think about trying again and replicating to maximize the opportunities for the kid to participate, be included, feel safe, and enjoy and learn. Communicate with the family members and other team members about noted changes and growth. It's going to be really significant. As we've mentioned, many kids with charge have so many medical issues that parents are generally exhausted, and they get more bad news than they do good news. So the smallest and slightest of successes, always feel open and interested in sharing those with the families, because every parent loves to hear good things about their kids. So notice the small successes, celebrate them for yourself, celebrate them for the family, and celebrate them for the individual that is your learner. And then if we haven't said it enough, we bolded it and made it bright red. Work on communication, because that is the cornerstone for everything. If you can read, know, and understand the wants and needs of the individual that you're working with, you are going to gain so much in every way if you really understand how to have meaningful conversations with them, include them in routines, give them choices, and making them integral in their education, their advancement, and their development. So we've included some really good links for you guys. The first link is to the CHARGE Syndrome Foundation website. And on there is just tons of stuff, information about CHARGE, information about events that are coming, you name it. But one of the things we wanted to make sure everyone knew is that they have a program through the CHARGE Syndrome Foundation, which is called CHARGE State Family Liaisons. And they are really awesome volunteers that volunteer for the board to represent their state to help make sure information from the foundation is getting to their families in the state, and then help connect them locally to resources and support. And so we would encourage everybody on the call today to go to that link and see if in your state there is a CHARGE State Liaison. And if there isn't, and you know someone that might be interested in volunteering, the foundation would very much love to hear from you. And the woman that you would reach out to from the foundation is Minnie Lambert, and her contact information is included on that link where the liaisons are listed. The other place that we link to here is the National Center on Deaf Blindness. And as I mentioned on the opening slide, that is where I work. But the reason why I'd like you to know about our website is because we work hard to curate all the learning opportunities for deaf blindness across the network, including CHARGE, on our website. And so if you go to our events page on our website, you can subscribe to get updates. so that it will let you know when we have events and trainings that are happening that families and professionals can take advantage of attending for free. We let you know when and where those are going to be. The other reason why I would like you to get on our website is because we have a For Families section that's devoted just for resources and support for families. And so it would be a good idea for you guys to peruse that section of the website. And as you work with families, make sure they're aware that those resources exist, because that way they can get connected to what's interesting to them and what they need. And then Susan has a book that she's going to show you all that's just fresh off the press. And we didn't include it here because it's so fresh off the press that we did not put the link to it. But when they send the communication out to you all after attendance of this webinar, they will send you a link to where this can be ordered. But Susan, do you want to tell them briefly about the book?
Sure, I'm happy to do that. This is the second edition of the Charge Syndrome book. That's the name of the whole book, Charge Syndrome. In 2011, the Charge Syndrome Foundation for Folks organized an edited book, and it was the first book published in the world dedicated to Charge Syndrome. And finally, Tim Hartshorn and Meg Hefner, who were two of the original 4 editors, decided it was time to update it and write a second edition. So this is the second edition of the book, and they worked this time with Dr. Kim Blake from Canada. So for you Canadians, we got a Canadian editor on here. And I think it's a wonderful book. It has topical chapters. There are 32 chapters, and they deal with individual topics. This is like 2 weeks out, okay, from Plural Publishing, but they're divided in categories like sensory issues, but then within that, there's a chapter on each sensory system. Then medical issues, and there's a chapter on each basic category of medical issues, and developmental issues, psychological issues. You know, we could go on and on. So bang.
Ladies, that was fantastic. This is Marilyn speaking. There's 2 questions here in the chat box I want to grab real quick here. I am so excited that you touched on all those variations of not only the vision, but also the hearing too. I mean, Susan, you really hit it right there on the head there when you're talking about the Hertz too. So many times providers only look at the paperwork and don't realize there's so much to Charge Syndrome. And that banana, I mean, I think all of us in this profession try to send that banana. It's the best way for people to see and understand, to comprehend hearing. But Robin does have a question here. I have one student I work with. The mom says her lower vision is very, very poor. But you said upper vision. Question.
This is Susan. I guess Megan's going to let me talk, so I'll talk. Again, 2 things. First, variability. Megan and I would want you to take away from the fact that even though we've described this litany of characteristics that typically describe individuals who have Charge Syndrome, every individual is different. And, although it is very, very, very common, it is most common that if individuals with Charge have a vision loss, upper vision is what is lost. And that's why kids cock their head back, so that even though they look like they're looking at the ceiling, they're looking straight forward. That is the most common. With that said, if this particular teacher's experience, the mama says her child has low vision loss, as Megan said, those folks know those kids better than anybody else. And it's not an impossibility. We're just trying to present to you what we think are the most common characteristics for which to look.
Thank you, Susan. And the other one is Deborah has on here. What is a typical eligibility assigned to a student with Charge Syndrome?
I'll let you take that one too, Susan.
This is Susan because Megan is deferring to me. I guess the the thing I would caution you about, first of all, is remember, please, the slide on intellectual development that says 40 to 50% of individuals who have CHARGE syndrome show no cognitive impairment. So even though in my experience, a lot of kids, particularly toddlers, early elementary kids, they are classified as having severe multiple disabilities, severe cognitive impairment. I think that is a mislabeling. It may be that at that point in their development, they're not functioning as age level peers because they don't have communication. As Megan said, red, bolded with a million exclamation points. I've seen kids categorized with the label, they get slapped with a label of multiple disability. Many of the kids that are appropriately categorized, in my opinion, are categorized as having deaf blindness, because most of the kids will experience some type of vision loss or some degree of vision loss and some type of hearing loss or degree of hearing loss. And as you all know, you don't have to be absent vision, absent hearing to have that label. And I think that, in my personal opinion, that's the label I see most often that seems appropriate. Sometimes it will be health impairment. I've seen that. I've seen physical disability. I've seen severe disability. I don't like that. I think that's inappropriate, personally. Am I opinionated? Yes. This is recorded, so that's scary. I think bottom line, in most cases, I would go with deaf blind being considered first as a more appropriate label. Megan, can you help me out? Do you want to agree or shoot me in the foot?
So this is Megan speaking. No, I agree. And oftentimes they check, that they have a vision impairment and a hearing impairment on top of having the other things. And that helps ensure that the parents can advocate for a teacher of the visually impaired and or a teacher of the deaf.
And so this is Marilyn speaking. And this is why we have these great short sessions to educate all of our awesome providers out there and the diverse participants that we have in these webinars to show this is just a short 90-minute session here, but we could talk about these things for a full day, full weekend, full week, and so forth. This is why we have our deafblind projects and our deafblind specialists and all of our regional reps out there. All of our family liaisons and many, many great connections that Megan and Susan have informed everybody of. Please utilize these providers, utilize the services that are there. They're free. They're available to help out to ensure that our consumers, our students do get that early intervention. And so they can start working on that communication as early as possible. So we really, really want to thank Megan and Susan for being here. You will all be getting a new link for Thursday. So look for that for Thursday. Up now is your poll. Just answer those 4 questions for us. And we truly appreciate Megan and Susan for your time. We look forward to seeing you on Thursday. Would you like to have any closing remarks?
No, this is Megan speaking. I would just say make sure to come on Thursday because the moms have done an exquisite job of preparing for this. And I believe it takes a lot of nerve to be brave and tell about your journey and the ups and downs. And so really come. They've been very thoughtful about what they want to say. And I think it's going to be a wonderful, wonderful 90 minutes.
And this is Susan. And I'm getting a horrible echo. I don't know why. I just want to echo what Megan said. The 4 moms, they've really put a lot of thought into their presentations. You'll see lots of pictures of their children on their journeys as they've grown up. The kids, their own children are different ages. So it's not only you're going to see little bitty kids, you're going to see older children. And they have some very powerful stories to share with you. And I just want to thank you for your attention today. Thank you for coming. Thank you for your interest in charge. Megan and I love it. And so we're glad to have the opportunity that you all have offered us to share some thoughts with you today. So I just want to say thank you. And do come back Thursday.